I've met all three of you. I'm Anjana Kundu. I'm one of the faculty on the pain medicine, and so obviously you see me in the OR as well. So I'm going to be talking at a warp speed about management of acute pain in children. And a lot of you have, all of you have been on call at this point, so you sort of know what sort of things come through, but we'll just go into a little didactic piece of it. And if time allows, we can sort of do a little troubleshooting of things that you encounter on call, okay? So objectives are just some basic definitions of pain, different kinds of pain, and then understand the consequences of poor pain control. And then just some practical issues as I was talking about it. And when we're talking, the middle objective is really broad. So not just like what happens if you don't treat pain, but also how to treat and assess pain, okay? So pain, by definition, this is the IASP definition, the International Association for Study of Pain definition. Pain is an unpleasant sensory and emotional experience. So we can't undermine the fact that it's not just what you feel physically, just the sensory or tactile feelings, but also emotionally. So there's a significant cognitive component to it. So even when patients can't verbalize it, it's still getting processed. And it can be associated with actual or potential tissue damage, or described in such terms. And what that means is basically in acute pain, you're going to see very obvious tissue injury or damage, whether it's acute illness, acute pancreatitis, or acute episodes of sickle cell disease, or mucositis in the hem-onc patients after their chemotherapy. So you're going to, or trauma, or burns. So you're going to see, or surgical sort of tissue damage. So you're going to see that. But where we say potential tissue damage is in terms of the chronic pain component. So where you don't necessarily see evidence of that injury right there, but it may have occurred in the remote past. One of the illnesses may have triggered it, and sometimes we can't even identify what might have triggered it. It might be just sort of repetitive use injury kind of thing, or carpal tunnel syndrome. So you don't really necessarily know when exactly it started, but there was a potential tissue damage. So we're not going to focus on the chronic piece, but just really important to have this sort of just the overall picture of what pain really is. And this is particularly also important because I've seen it on boards like as a multiple choice question, so like what the exact definition of pain is. So important to know that. So then you have different types of pain. So acute pain, we sort of talked about that there's a very defined onset, there's usually a limited course, and there's an actual evidence of tissue injury or damage that's occurring. So that's your acute pain. And it usually sort of signals that there's something wrong, meaning, you've just had surgery, you've just broken a bone, or something is wrong, and there's evidence for that. Chronic pain basically occurs when pain symptoms last more than 3 months or 90 days. People are debating that a little bit as to whether 90 days itself is the defining criteria, because something like amputation, phantom limb pain, or post-amputation neuropathy that you get starts right away, pretty quickly. So you don't have to wait 90 days, and it has all the characteristics of chronic pain. So there's some debate, but as of now, this is the best definition we have, is sort of like 90 days or 3 months. And you may or may not see the evidence of injury. Nociceptive pain means somatic pain related to injury, illness of bones or muscles, etc. That nociceptive means, or visceral organs. So there's actual tissue damage, either it's the musculoskeletal system or the visceral system. And usually what you'll see with the visceral pain is it's more due to inflammation or distension of these organs rather than sort of an actual injury, so to speak. Neuropathic pain, one of the hardest to treat, one of the hardest in terms of even its recognition. So we do have certain defining characteristics of neuropathic pain, but it still is pretty hard to diagnose in some cases because you don't necessarily have an identifiable cause always. So pain is initiated or caused by a primary lesion or dysfunction of the nervous system. could be peripheral or it could be central. So central would be more post-stroke kind of central pain syndrome or anoxic brain injury. Then subsequently they may be having sort of pain episodes or agitation episodes. That could be the central pain. So what we call storming. Why should we treat pain? Because untreated pain causes harmful physiological effects. We know, and we're going to review that briefly. And severe pain causes extreme discomfort and suffering. So that by itself should be a pretty good reason for us to want to treat it, because it's got pretty profound effects. So what are the adverse effects on organ system, sort of the physiologically looking at it? You look at pulmonary systems, you have increased shunting, decreased flow volumes because you're not breathing effectively. When you look at the cardiovascular system, you've got increased heart rate, cardiac output. So there's increased workload basically on your output. So there's increased workload basically on your cardiac system. And it's much more important in the adult population that you're going to see who may have at-risk myocardium or at-risk heart tissue to begin with. Children, you don't find that as much of a problem, but still it's really important to know, because you're not always just treating children and all healthy children. The other two areas that are really important and less talked about in general, but definitely gaining more press, are effects of untreated pain on the immune system. And there's also definitely evidence to suggest that some of the things that we use to treat the acute pain, like opioids, also affect the immune system negatively. But really what we've seen is it's much more harmful if you don't treat the acute pain rather than when you treat it with opioids. So opioids do suppress the immune system to some extent, dose-dependent, prolonged duration of use of it. But if you don't treat it even for short periods of time, you'll have immune suppression. So delayed wound healing, so it just absolutely increases the mortality and morbidity and maybe even mortality of patients. Endocrine-wise, you have elevation of stress hormones, which again will, they can increase the impact on your peripheral, or various organ systems. Your cardiovascular system, pulmonary shunting can be increased, but more so it will also impact your immune system too. So definitely really sort of intertwined and has impact on the outcomes postoperatively. How do we know all that? Because there have been studies of people like Sunny Anand, who's been one of the pioneers in sort of acute pain management, with Paul Hickey from Boston came out. This was one of the landmark studies that came out in the mid-'80s to show what the impact of untreated pain was in neonates and infants, basically, who were born with cardiac lesions, needed cardiac surgery. At that point, we were doing minimal anesthesia and really no analgesia. So small amounts of inhaled anesthetic, lots of pancuronium, get the surgery done, and really not a whole lot of intraoperative or postoperative analgesia being used at that point, because at that point literature didn't have a lot of support for what happens if you don't treat pain in children. And the very popular belief was that children don't really respond too adversely to pain, or they may not experience it as much as the adults do. So on the contrary, they actually found that they when they're subjected to surgical stress with minimal anesthesia, they actually have a substantial amount of catabolic reaction. So they actually measured the catecholamines and followed their morbidity and mortality postoperatively. Compared two arms with kids that got fentanyl intraoperatively and kids that didn't, just got the usual care, which was the minimal anesthesia. And there was a substantially higher mortality and morbidity and higher amount of catecholamines sort of measured in the serum postoperatively in the group that had minimal anesthesia. It also sort of triggered, since the 70s, there's been more research on the neurobiology, trying to understand what happens to the pain pathways and like and then what happens to pain pathways in your early childhood or even in intrauterine life, and what does it mean? How do they conduct the stimuli or how do they conduct the sensation in general? And by the 90s, they basically had come out with a lot more evidence and showed that there are slow lower tactile thresholds, so it means they really perceive it much quicker, much faster, and there's a decrease in threshold after exposure to painful stimuli. And what that means is this actually results in sort of prolonged and more painful conditions. And so when you're little, you can quickly perceive it and you can have a long-lasting impact from it. And what we're going to talk a little bit more about it in clinical studies. And it also, because they have shorter distances to travel, in terms of the sensations of shorter distance to travel, because their whole nervous system is about this big. So they even though they're unmyelinated, they actually travel much faster, and they spread to multiple levels much quickly as compared to the adult sort of sensation. And the other thing that we're going to talk about is that they also don't have the ability to regulate or downregulate these noxious stimuli that they experience. One other reason why we treat pain, because it's mandated. So we are governed by regulatory authorities, and JCAHO, being one of the big governing bodies, tells us that we need to have good measures to evaluate pain, to treat pain, and reassess it, and that everybody needs to be trained, whoever is going to be treating or coming in contact with these patients. And above all, the AAP and the American Pain Society, they issued a statement, policy statement, saying concept of pain and suffering go well beyond that of a simple sensory experience. So it has a much more prolonged, long-lasting effect. So we need that. It actually deserves a lot more attention than we have been giving it. So what are the barriers to effective pain management, especially in children? Like we were talking about, there was the myth that kids don't really feel pain, or especially the younger ones, the infants, and infants and neonates don't feel pain just like the adults do. And that it takes too much time, we don't have good tools to assess them, and really there's concerns about that. We don't have the adequate information to effectively assess or treat their pain, and also worry about what the effect of these analgesics on sort of younger children is going to be. So we doubts about their physiology and pharmacokinetics and pharmacodynamics. So as we were talking about that, actually kids do feel pain. We saw that at least physiologically in that study by Paul Hickey and Sunny Anand. But then neurodevelopmentally, we found that there are neuroanatomical components of pain as early as second trimester. So between 20 and 24 weeks of gestation, you're going to have all the fully developed ascending pathways. So they are capable of carrying all painful stimuli. What's lacking is the descending pathways, and descending pathways are where our inhibitory neurons lie, which is what modulates pain. So when you hit your elbow, or and you just you rub it, or you whatever, after a few explicitives, you're going to try and apply a counter effect. And what that's doing is triggering the modulatory pathways for you, so it sort of regulates. And you don't necessarily even have to rub it to trigger those. There's automatically sort of when your ascending pathways carry the signals, it gets interpreted in the brainstem and your cortex. That itself then activates your inhibitory pathways, so that so your pain doesn't continue to perpetuate and go on uncontrolled, unmodulated, so that starts to dull after a little bit, right? And that comes from the inhibitory pathways. That's not there in neonates. It doesn't really develop up until, it starts developing around 6 months of age, and sort of may take about 9 to 12 months of age by the time it really gets to be any effective at all. And by 2 years, you have a lot better way of sort of modulating the pain. The other thing is that the children's, the developing brain, so young children's brain is much more plastic, or their nervous system is much more plastic. What that means is that it's very moldable. It's like putty. It's Play-Doh. You can shape it however you want. You as an insult or injury, or you as an interventionalist who can treat and change the course of the effects of that injury. So what you do after a noxious stimuli can completely alter what the outcomes of children's pain or this noxious injury would be. Because if you leave it unattended, it will have, because they can mount a bigger response, because it spreads to multiple levels, you can have a very profound pain syndrome. Whereas if you impact it, treat it and adequately, you can completely shape it towards a very normal development and have so much more complete recovery in pediatric patients as compared to adult patients, and much quicker, because their brains are capable of reshaping itself much easier. And that's why in chronic pain, you're going to see differences in treatment of complex regional pain syndrome in adults and children's. You'll have so much more positive outcomes in pediatric patients compared to the adults, and with very little intervention. So normalizing their activity, getting them to desensitize, will take you much farther compared to what you could achieve in adults, where you're going to do a lot more interventional stuff and still may not be able to gain back all those positives that you can in children. Just a pictographic representation of differences in their receptive fields. Basically, neonates has no inhibitory sort of mechanism, therefore their receptive fields are much bigger, so they can sense more intense, whereas the adults, you've got the inhibitory pathways. As I talked about, they may have unmyelinated sort of neurons, which means it's slower conduction, but because their distances are much shorter, still their speed of transmission of noxious stimuli is much faster. And we've talked about the other points tremendously before. So here's a clinical study which looked at comparing children, looking at distress from immunization in young children who had a circumcision or didn't have circumcision. And amongst the group that had circumcision, looking at whether they got any analgesic at all, or was it done without analgesia. And it was a prospective placebo-controlled study, 87 patients, and then they basically videotaped the distress from these children's immunizations. So at birth they had circumcision or didn't have it, got analgesia or didn't get it, and then up to 6 months of age they followed their immunizations. And they took videos during their immunizations and sent them to completely blinded sort of observers, and they scored their distress and pain scores. And what they found is that kids who were never circumcised had the least amount of distress. Kids who were circumcised definitely had more distress. And even in that group, the two groups where they had some analgesia versus no analgesia, there was a tremendous difference between those two groups. The ones that didn't get any analgesia at all, no topical, no regional, nothing like that, were definitely much more distressed. Their VS scores were higher, their distress scores, behavioral distress scores were higher. So what they said was obviously that the tissue damage during infancy led to a sustained central neural function which persisted even after the wound healing had occurred. So that, remember, we were talking about potential tissue damage, so that was the potential that we were talking about. So pain is subjective. There are some tools for assessment of pain. We have, I'm not going to go in details, but here are some of the most common tools that are used. What I don't have listed here is what we're using at Children's at this point. We used to use the MIPS, but now we've changed to NPAS, which is also pretty similar, but it also takes into consideration just the agitation scores and sedation scores, which we don't have on this list. So the Modified Infant Pain Scale, or the PIPS, is the premature infant pain scale, where you take the gestational age and some of their physiological characteristics like heart rate, respiratory rate, and blood pressure into consideration as well. Then you have the FLACC, which is the face, leg activity, and cry and consolability scores, which is observational. Again, the MIPS, the FLACC, the CHEOPS are all observational pain scores, which means the sort of you observe and score based on what their behaviors, their facial expressions, and muscle tone, and how easily they're consolable, or what what their behaviors are in response to distress. So those are observational pain scores. And then we actually have numeric, or sort of self-reported pain scores, which could be the Wong-Baker pain scales for kids between 4 to 7 years of age. They can look at, or the p.r.n pain scales, which is what we're using, again, just modified at Children's Hospital. The Wong-Baker face scales are really cute and sort of cartoonish, and kids actually take to it a little more, but the p.r.n pain scale is much more validated. It's much more adult looking, or as most of our patients say, they're more alien looking, so they don't really take to it so well. But it's much more validated because the scoring system is much more accurate with the p.r.n scales. And then you've got the visual or verbal analog scale, and the numeric scale, which basically they can look at the color and indicate how high their pain is, or they can look at the numbers and say, this is how high my pain is. So when do you use each one of these? Less than a year, you're going to use the MIPS or the NPAS at this institution. Between 1 and 3, the FLACC is a very good score, or for cognitively delayed kids, FLACC is a very good pain scoring system. Between 3 to 7 or 4 to 7 is the Wong-Baker or the p.r.n pain scale, and then between greater than 7 years, it's the numeric scale. Okay, so all the details, you all have these in your handouts that Casey sent out, so you can take your time and look over the details of all the different assessment tools. So here's the cute little cartoonish looking Wong-Baker scale. So now we know how to assess pain, we know why we should assess and treat pain. How do we do it? Uni-modal approach, I shouldn't even have it there, but I keep it there just because sometimes we tend to think, as you know, we're anesthesiologists, we do an intervention, we assess that rather than certainly, and then we go sort of systematically give something, you see the results. Whereas pain is, because we talked about how sort of multifaceted it can be, even in acute states, that we need to look at it from a multimodal perspective. So what you do with your medications may not necessarily be enough. What you do by soothing a patient, or just doing comfort measures, or repositioning them, or distracting them with a toy, might be a tremendous gain. So just keeping that in mind makes sense. Makes your pain management much more effective. Plus, not just sort of like your cognitive stuff, but even with medication, obviously we don't do that anymore, but for a long time we would pick up one thing, like pick the opioids or pick the non-steroidal anti-inflammatory, and unless that failed, we never went to something else. So, but at this point, the goal is try to use multiple medications to get the adjuvant analgesic effect, to reduce the side effect profile of different medications, and get the best analgesic outcomes. Preemptive analgesia is still a very debated topic, whether you can intervene ahead of time and change the outcomes. But the one clear-cut evidence we have for preemptive analgesia was for people who underwent amputations and had up to 48 hours of regional anesthesia, epidural in this case, to prevent occurrence of phantom limb pain postoperatively, and it was pretty successful. There were lots of studies related to non-steroidal, especially Celebrex and the COX-2 inhibitors, and as preemptive analgesics, but obviously that literature has been questioned and withdrawn at this point because of the credibility of the person who conducted the research. So we don't have great evidence for preemptive analgesia. So we should always utilize non-pharmacological agents when we can. And pharmacologically, we've got local anesthetics, we've got opioids, we've got other adjuvants, and of course the non-steroidals. So kids, just things we were talking about physiologically, children are different. They have larger volume of distribution. So when you dose their medication, keep that in mind, that you may have to reduce the dosaging based on that. We dose them per kilo. They have less protein binding, so a lot more free drug available, again, making it imperative for us to understand that we should dose adjust. And then really the infants under 6 months of age, they don't have the hepatic and renal maturity, which is also a big factor in a lot of metabolism of a lot of medications. So we need to keep that in mind. All right. So the WHO suggests how do we go about using different medications. For mild pain, you don't necessarily need much more than just your acetaminophen and basic non-steroidals. Again, at every step, WHO at this point says add adjuvants. So you can add adjuvants at any of these levels. Moderate, you got the weaker opioids. Codeine is very debated at this point. A lot of people in pediatric hospitals are actually taking it off, but in adults, it's still used a lot. Tylenol with codeine is sort of adolescents and adults are still using that a lot more. So that's why I have it here. But in pediatrics, majority of the institutions are not really using it as much. It doesn't have as good an analgesic capability. Plus, about 15% of the population, certain populations actually lack the ability to convert codeine into morphine, which is how it exerts its effects. So people are thinking, why not give morphine itself when it needs to go that way anyway? Plus, the ceiling effect for analgesia is reached much quicker, and you get a lot more side effects of constipation and nausea with codeine as compared to well, not as compared to, but in general, that's what you start having side effects quicker than you get the analgesic efficacy. So, but that's really the only one that falls into the weaker opioid category. And then you're talking about oxycodone, hydrocodone, and morphine dilaudid as your next step. Certainly, at every point, you want to utilize your non-medication options as well. And then physical interventions would be sort of optimizing positioning or activity or use of TENS unit, anything that you could do to help management of your pain. Usually avoid p.r.n.s when you can, especially after post-surgery, because you're going to avoid the highs and lows. Starting dosages should be smaller. You can titrate to effect quickly, and then of course maximize the dose before you give up on any agent. All right, just a diagrammatic representation of what you do, what happens when you give p.r.n. or Q4 as opposed to a continuous infusion where it's going to be much more smoother. So looking at Tylenol dosing, that's controversial again, a little bit. Especially rectal Tylenol, because the dosaging is very variable. People will give anywhere between 15 to 40 milligram per kilogram. And there's a study that looked at what the optimal rectal Tylenol dose is. Oral dose we know pretty much between, you up to 15 milligram per kilogram, but as long as it's under 75 milligrams per kilogram per day for a daily dose. But rectal Tylenol is different because the absorption is different, it's variable. So they looked at children who were undergoing surgery, getting rectal Tylenol. They drew blood samples for about 24 hours, excluded the liver and renal diseases patients. They monitored their serum levels post-operatively and found that most consistently, if you gave 40 milligram per kilogram, was sort of the best most consistent range in the therapeutic range was with patients who got 40 per kilo. Most of the other ones stayed in the lower ranges, but still there was a huge variability in terms of where they sat in their therapeutic range. And then subsequently, the subsequent dosages were required to be under 20 milligram per kilogram. So you needed the 40 milligram per kilogram as the first dose, but then subsequently Q4-hour dosaging you could maintain under 20 per kilo. And none of their patients really got any toxicity getting dosages up to 20 per kilo. So recommendation was that if you give 40 as an initial dose, maintain it at 15 per kilo rectally, that would be pretty helpful. So ketorolac, there was a study done here by Ann Lin looking at ketorolac in infants. I mean, obviously that's controversial also a little bit. It used to be, not anymore. There's a lot more evidence under 2 years of age at this point, but we used to have to jump through many hoops to give it for kids under 2. But basically they said it was safe. It actually might have a little more rapid elimination compared to the older patients, and especially the S isomer that these guys used in their study. And then you may need to have even shorter dose intervals than Q6 hours. I'm not going to go into local anesthetics because you guys have already a separate lecture as far as I know. So you can use it topically, you can use it as regional catheters or neuraxial blocks. And just a little focus on what happens with neuraxial analgesics. We have several studies indicating that epidural analgesia accelerates the recovery following surgery, especially major abdominal and thoracic surgery. This was a urologic surgery. They showed that time to extubation, stay in the ICU. Older study, as you can see, when they major urologic or abdominal surgery would go to the ICU. But certainly outcomes were much better in that time. Again, very complicated Nissen fundoplications when they were doing open Nissen fundoplications on more older people at that point. Much more evident that kids or youngsters who got epidurals did much better. What about adjuvants used in the neuraxial blocks? Clonidine, what happens when you add clonidine, because you hear about it. So addition of clonidine definitely prolongs the duration and the intensity of your caudal blocks if you give it. But what it also does is sort of increases the sedation a little bit. So you want to be mindful of that. There was also a time, like about several decades, when clonidine had fallen out of favor to be given through caudals because it was associated with respiratory arrests and respiratory depression. But it turned out that was dose dependent and for premature kids. So as long as the dosages are under 3 mics per kilo, and kid doesn't have, an infant doesn't have prematurity as a risk factor, and they're still under 60 weeks, they're above 60 weeks at this point, then you're relatively safe. So nobody really doses it at 3 mics because you're also going to get hypotension, especially under anesthesia. So most practically, looking at it, I see best outcomes with about 1.5 mics per kilo. Although if you give 2 mics per kilo dose, it actually gives the duration a little more than it does at 1 or 1.5. But you get less hypotension with 1.5 mics. It's still pretty close to 2 mics per kilo analgesia duration as well as intensity. So same, like more of the same. Then looking at ketamine, some people have used ketamine. I'll start out with saying that we don't have the ability to use ketamine here because the form that we give in the United States has a preservative that's been associated with neurotoxicity, clearly in much higher dosages directly applied to the nerve structures themselves. But in Europe and other countries, they certainly have the S isomer, which is not which is not associated with neurotoxicity. And they basically, I mean, there's a variation in use of adjuvant analgesia with ketamine. People have convincing evidence both when you give it IV as well as through neuraxial routes. In both cases, you're going to get prolongation and a better analgesia. So for us, practically, adding a small dose of ketamine IV could give you increased analgesia, even increased effects even on your regional anesthesia postoperatively. So, and there were no differences in their post-op incidence of nausea, vomiting, or psychomotor behavior, which are the big concerns we have. The hallucinations and psychomotor behaviors post-agitation after giving ketamine, and nausea, vomiting. Those are some of the most common side effects that you're going to see. I'm also not going to review opioids because you use it so much more commonly, but just all these various routes you can give through. You need to be aware of the side effect profile, which you already know: constipation, respiratory depression, itching, somnolence, urinary retention, some of the most common things that you're going to see. And myoclonus, especially when you see patients on PCAs on the floor with higher dosages and they're twitching, or continuous infusions that you have to escalate, and suddenly the kids are going to jerk every so often. They're not able to rest, and then they cry because they've had a surgery and they have these jerking movements that exacerbates their pain. So something to be very aware of. What can you do to treat that? You can give some benzodiazepines. That'll reduce the dose, reduce the myoclonus incidence. You can, of course, reduce the dose of your analgesic. You can change it to a different agent. So if they're having myoclonus with morphine, they may not have it with hydromorphone, or vice versa. And you can add clonidine as an adjuvant, and that'll reduce the incidence of myoclonus as well. So just things to keep in mind. All right. I don't think we have time. I'm happy to go over some of the cases if you guys have time, but if we, otherwise, if you have to go get your cases started, that's fine too. There are very few slides left really quickly, but whatever you want to do. 4 more minutes, 5 more minutes, or you need to go? 4 minutes. So, 4-year-old, excision of neuroblastoma, T8-9 thoracic epidural, because there's a big abdominal sort of or subcostal incision. Now is complaining of 8/10 pain on what scale? FACES scale. Or you could, and even the nurse has FLACC them at 8/10. So using the FLACC scoring. So what do you want to do?
I'd go check it out myself, see if I actually agree with the assessment. In terms of, whether I can distract the kid and then, kind of touch the area where I'd expect his block to be, and see if he's still responding or not, to try to decide if there's actually a block or not, or if it's maybe a unilateral block.
Right.
Probably if I agree with 8/10 or even anything close to that, I'm going to end up giving him opioids or increasing his opioids if he's already got some. I think in kids often you need to do that with.
Okay. So you tested, and how are you going to test it?
Well,
4-year-old who's just crying nonstop.
You can't really use ice.
Yes, you can.
Well, all right. Then if I can do that, then that's
okay. Put it in a glove. Just try, do your best. They're going to cry, and you're going to see the difference in there. Plus, you're going to be able to see whether they're moving or just sort of staying still and crying. That would give you an idea of how afraid they are to move. Or are they just crying when you walked in the room versus when mom was there? So those may be the differences, again, to distinguish. And you know what? The other thing, the most important thing, this kid had a neuroblastoma excision, has a big old NG tube, and turns out he's crying. The nurse says it's abdominal pain. Kid says, this. I want this out. He's crying. So it's really important to assess where the pain is. So it could be the NG tube that's distressing it more than anything. And you could be pushing on the belly and it's just fine. But the NG tube could be a source of distress, or because he can't eat, or because so assessing the source of pain or source of distress is really important. Absolutely make sure you can detect a level. So what if you don't detect a level? Still give opioids?
Yeah, I think so.
You've got an epidural.
If you don't detect you mean if it's working?
Right.
Then you can bolus the catheter.
Right.
Yeah. If it's working, yeah, you bolus the catheter. If it's not working, then you give opioids.
Right. Absolutely. So troubleshoot. Or the other caveat would be that, the pain's all well controlled, but they've got a total motor blockade. Then what are you going to do? They just can't move their feet at all.
So you should stop the infusion.
How long?
For an hour, and then reassess.
Right. So until some movement comes back. So obviously don't wait for it to completely wear off. If some movement, some sensation will come back later than the movement will. So assess whether some movement comes back after an hour, 2 hours, whatever. Whenever you see the signs of block lightening up, then you can so basically either make it less dense with less concentrated medication or less rate, either way. So you go. If you see nothing in 4 hours, you've had the epidural off for 4 hours, still no movement, send them to MRI. Make sure the team knows. When you stop the epidural, make sure the team knows that it may just be a dense block. You'll reassess in so much time, and then so that they're aware as well. And if 4 hours, there's not. It's rare that happens, but something really you have to keep in the back of your mind. So that's troubleshooting for epidurals. It's all in your resident handout book and all the little diagrams as to how you're going to dose them, how you deal with unilateral block. All that is done there. You may consider adding adjuvants. You may consider adding opioids. Similarly with peripheral nerve catheter, you want to test the block, you want to check the site of pain, you want to optimize your analgesics, right? And you know how to troubleshoot PCAs already, so you guys are doing very well in that regards. So thank you for staying with me, and have a great day.
Thanks.